professors.
Hello.
Hello.
Welcome to the Scientific Café hosted by the Brocher Foundation. Today we're tackling a fundamental question. Can we make healthcare fair? Should everyone access the same level of treatment, or is it inevitable or even acceptable that some people receive better care than others? Now, you're both here at the Brocher Foundation as part of a week-long summer academy tackling this very question. So could you both briefly introduce yourselves and share a bit about how your work relates to this question of fairness in healthcare?
My name is Alicia Yamin, and I teach law and public health at Harvard University. And my focus is really on applying human rights frameworks to health and health systems. So that's the angle that I come at this from.
And I'm Ole Norheim. I'm a medical doctor and a professor of ethics at Harvard University. I worked in Norway for many years on priority setting, fair priority setting in the Norwegian health system. Now I work more in low-income settings, especially in East Africa and in Ethiopia.
So to get the conversation started, what do we really mean by fairness in healthcare?
Yeah, the way I think of it is that every citizen would like to have a long and healthy life. And some of us are unfortunate and get sick earlier or later in life. And I think a fair system would provide universal access to the best services that can help us to live long and healthy lives, and also to reduce these inequalities in health outcomes. And by universal, I mean that everyone should have access to these services, whether they are rich or poor, whether they have come from different ethnic groups, different genders, and so on.
I would add that health is particularly tricky to talk about fairness and equality in, because sometimes people who are worse off aren't necessarily marginalized because of their race or ethnicity or gender, or even because of class, but also because of the health condition that they have, or a certain impairment or condition. So all of that needs to be taken into account when we discuss fairness in healthcare.
So what's an example then of a system that's more fair or less fair than others?
Well, I would start out with a system that really gives much better access to people who are wealthy is arbitrarily unfair. So, for example, in the United States, where poor people get poor quality healthcare. I think another wealthy country like Canada does much better at establishing a universal system than the United States, with defects and flaws. There's no country that's perfect. Norway is also an example of an excellent universal system that comes close to fairness in healthcare for its legal citizens. And then there are some countries that are lower income, like Costa Rica, that do quite a good job with much less GDP.
And I would add to that a fair system, it's also about who's paying for this. So there's no free healthcare. I think especially the healthcare system that are tax-based and where you have progressive taxation. So a healthcare system actually is redistributive. So we often say that we should prioritize or allocate resources according to need, but pay according to ability to pay. So actually, a fair system will ask people who can bear the burdens to pay a bit more, so that we can use the shared resources to care for everyone.
If we can't afford to give everyone the best care, what should we prioritize?
Yeah, so in my view, and for example in Norway, we have criteria and principles for that. So we have these fundamental principles of equality, of the ideals of equal access. But also in practice, there are many new technologies, treatments now coming that are very costly. And some of them provide modest benefits. For example, some cancer drugs can improve survival with 10 to 15 to 20%. That is very meaningful for the patient. But if you look at the alternative cost, you could have spent these resources on other patients who need it even more. So in practice, we often say no to some very costly new services that provide modest benefits.
I think, in human rights, some of my colleagues argue that you can always spend more money. The right to health could mean having a right to everything, all treatments right away. And I very much agree with Ulla's view. There's a bottomless need for healthcare. So we do have to prioritize, but it's very important to do so in a way that is explicit and transparent and provides reasons to people and allows for deliberation, so that, because healthcare policy is one of the areas which so clearly is about who gets to exercise power over whom and of what kind, and that has life and death consequences.
And I would add to that I agree that having an explicit system that we can discuss and criticize and improve is good. But in practice, we often see that priorities are made a little bit more ad hoc or implicit. So sometimes we set priorities by delay. So if we think something should have low priority, people are put on waiting lists. Sometimes if you don't have enough resources, you will reduce the quality of care. And the systematic effect of this is that we often see that patient groups that have a low voice in society, for example, mental health patients or drug addicts, in the case of Norway, they tend to get poorer quality of care. So the idea is that if we have a more systematic approach to priority setting, we can also compensate for these ways the health system work with more implicit priority setting.
And most importantly, that it not be set by the market.
Mm-hmm. Because we often hear that healthcare costs are rising. Why do you think that is?
Yeah, so there are many explanations, of course. One is that doctors and health professionals get higher and higher salaries. And then there's a lot of innovation. New drugs are coming on the market, and some of them are excellent and very good, but they tend to be very costly. And the way we have organized the production of medicines, for example, that are very much led by pharmaceutical pharmacies, companies, and sometimes they ask for high prices. And they know if they have a drug, for example, that can save a patient who is very ill of cancer, for example, they can push the price quite high up. And there are also some new genetic therapies that are really costly to produce, that are tailored to small groups of patients. And so there are some real costs as well with some of these new technologies that can be very, very good.
Many countries allow people to pay extra for better or faster treatment. Is that fair?
My answer would be it very much depends. If there is a universal system that provides what is an adequate level, these words are very loaded, right? An adequate level of coverage for the entire population, allowing people to buy additional services that are non-essential, and which doesn't detract from the universal program, I think is permissible, yes.
So it's very interesting. This has been the key topic of this Summer Academy. And we have had a lot of philosophers and lawyers and other experts discussing this. And surprisingly, there's a lot of agreement, actually, that given those conditions that you mentioned, that one might allow a second tier of low priority services if it doesn't affect this a quite robust universal basic tier. But in practice, that's very difficult. And in my country, for example, Norway, there's a lot of political opposition to allowing a second tier. We are slowly drifting into that. So some people will buy insurance to get quicker access on the waiting lists, and a few other services, but we are not allowing a large second tier. And one of the arguments is that we have, even if we have a lot of health personnel in Norway, many feel that the private sector then takes maybe the best doctors, or at least take doctors, so we get scarcity of health personnel in the system. So a lot of people in Norway argue that the second tier is actually reducing the quality of the public healthcare system. So in principle, I think many of us agree that we could allow, because as Alicia said, the need for healthcare is almost bottomless, and in Norway we pay 10% of GDP to the health services, and we want to also prioritize school and education and other services. So we can't pay 40% for health services, and if people want these other extras, it's hard to ban it totally.
I think in the real world, we've seen examples where allowing private healthcare does undermine the public system. Brazil, for example, has a magnificent universal health system. It's enshrined in the constitution, but there are these private providers that have undermined financing for the public system and have sucked away providers into the private establishments.
I'm wondering if on the flip side, having that second tier could maybe help fund innovation with the extra funds. Is that a possibility?
So some argue at least that it can help relieve, so it can shorten the waiting lists, and maybe you can have quicker uptake of new technologies, sometimes better services. So there are some advantages there, absolutely.
Should all countries aim for the same healthcare ideals? Or do you think that fairness looks different in different contexts?
Yeah, happy to discuss this. So I work both in Norway and in Ethiopia. And in Norway, we're a very rich country. We have oil revenue and taxation and all of this. So we spend $6,000 to $7,000 per person per year on health services. In Ethiopia, they spend $35 per person. And that's 1/3 of that comes from government that they're able to collect through taxes. But it's very hard to collect taxes in a country like Ethiopia, where a lot of people are farmers, 70% or more live in rural areas, informal economy and so on. 1/3 comes from external donors, like the US aid before, and from other donors, the Global Fund, very important to help save lives. And 1/3 comes direct out-of-pocket expenditures. And that means that the total of $35 is too little to provide the same quality and same access to the type of services we have in Norway. And my view is that it feels, and I think it is unfair, that a lot of kids in Ethiopia are dying from diarrhea and pneumonia and simple things that we know if they had more resources, they could have saved these lives. And the aid that is provided helps a lot, but much more is needed. But I don't think we can expect that a developing country like Ethiopia can have the same level of services. And there is no willingness and no agreement that global justice require completely equal level of services. But I think this big difference that we see is unfair.
So as a human rights lawyer, I mean, human rights is about the obligations that states owe to their citizens, or sometimes a little bit more broadly, social citizens as opposed to legal citizens. And clearly in a country like Ethiopia, those obligations are limited under international law and domestic law by resource availability. So the right to health is considered a social right, and it is subject to progressive realization in accordance with the maximum of available resources. Having said that, there is also this idea of a core minimum, which you could translate to an essential benefit package. Sometimes under domestic constitutional law, that is taken as the social insurance package, which is given so that people actually have a right to claim that. If the government says it's going to do that, then they have a right to claim it. So the packages do differ across countries, and I would underscore what Ulla said, that it seems that it is, in fact, very unfair. And many of the countries that have such low resources don't have such low resources just as a fact that is outside of history, right? They are the way they are because of colonialism and enslavement and extractivism and the shackles of debt, et cetera. So I think that those layers of unfairness really need to be taken into account when we think about global health justice.
This one's a more hypothetical question, but if we were designing a healthcare system completely from scratch, what do you think is one of the more important things for us to be getting right?
Well, I can tell you one of the things that should not be done, which is what has been done in almost every country in Latin America, which is to set up segmented health systems with some people who work for the government, and then or the military, and then people who are in the formal employment sector, and people who then have a subsidized regime, because it is very, very, very difficult politically to overcome that segmentation. And it entrenches itself, and it entrenches structural injustices.
And I would add that I think if you started it from scratch, and even when you try to reform health systems, you need to think about setting priorities. Because what we think about as health and health services can be so many different things. And making sure that the most important services are provided. For example, vaccines for children, safe birth for mothers, clean water, hygiene, public health protection of people, and really thinking through what is most important and what can help people live long and healthy lives. And then accepting that there might be some other less important health services that would have to wait as you get more resources so you can improve and build your health system.
And in a way, both of those are saying the same thing, because in those segmented health systems, there's not a universal sense of what we should set as priorities. Each segment does that. And I think I would add to start with primary care.
You've both answered my own question of, in this real world, the one that we live in right now, what can we do to make healthcare fairer around the world? And it sounds like it is tackling those high priority areas like vaccines and the ones that you were mentioning.
Yeah, and also reforming the way services are paid for. Mm-hmm. So especially in many low-income countries where they haven't really been able to provide public services, publicly paid services in a good way, so they end up by direct out-of-pocket payment. That is both unfair and inefficient because you get sudden shocks. Your mother gets cancer and you have to pay a lot of household income to pay for her services. While if you buy insurance, or if there is a kind of insurance mechanism, you are more protected against these financial shocks. So thinking about how the financing of health systems are organized, that's hard to implement, but a lot of countries are trying to do that now with the support from the World Health Organization, the World Bank, and others.
I think that goes for higher income countries as well. And in low income countries, I think we do really need to pay attention to illicit flows of finances out of the country so that the country can actually have a good amount of resources to dedicate to health systems, as well as other social endowments, education, and social protection.
Do we think that overall the fairness in healthcare is getting better or worse?
I think, it varies, right, among different countries and different regions and different subpopulations. But I think the extraordinary concentration in wealth, really in many, many countries across the world, which then becomes an extraordinary concentration in political power that distorts objectives, has a really bad effect on equality and fairness in healthcare.
Yeah, I will actually end on a slightly more optimistic note. I look a lot of health statistics, and I've published several publications on the trends in mortality, for example. And we have seen the last 25 years that under 5 mortality in the world have been halved. So it used to be much, much higher than it is now. And also life expectancy in many countries are going up. So there is a lot of progress. Some of that progress stopped because of the pandemic. And now some countries are threatened because of the cuts in aid to some of the poor countries. And we see some countries where there is increasing inequalities in health. But the general long-term trends are actually quite positive. We have more knowledge and more technologies. So even if we are desperate and think that things are always going in the wrong direction, if we look at the longer trends, there are some positive signs, at least.
So as we wrap up, what's one thing that you both hope people will take away from our conversation today?
Yeah, we have had many interesting discussions among philosophers, ethicists, and also economists and human rights lawyers and health professionals. There are many very interesting discussions about how do we think about a more fair and a better society. And if some of these thoughts can be translated into actions, I think we have achieved a lot in this conference. And we have actually agreed on a lot of these very hard issues. So I will say that even in ethics, there is a little bit of progress in our understanding and what fairness means.
I agree with that. I think actually that's a very positive thing. I would also say that this has been a wonderful week because there are very, very senior philosophers and academics, and there are young emerging ones. And to see the young emerging academics and philosophers really build on these theories and carry them further, I think is extremely promising.
And I want to add to that, I go to a lot of conferences, and typically it's very busy and you're allowed to speak for 10 minutes and then you rush to something else. And here we have spent hours discussing, presenting beautiful environments. We meet colleagues in the evening. And I think it's a kind of an old-fashioned academics.
Unique.
Very
really
unique. So we have, all of us appreciated that a lot, I think.
Yeah, well, that's wonderful to hear. And you've given us and listeners cause for optimism. So thank you for sharing your reflections and your thoughts today.
Thank you.
Thank you.